Hello, and welcome to the Cushings Support and Research Foundation webinar. This webinar is going to cover the diagnosis of Cushing's. Today we're going to have Dr. James Finn Ling speak to us about the process of being diagnosed and the tests that are involved. I want to mention that this is being funded by a grant from Strongbridge Biopharma. So I'm going to give a very short introduction to Dr. Finn Ling. Dr. Finn Ling is on the Cushing Support and Research Medical Board. He quite frequently contributes to our website and helps answer questions. He is a professor of medicine at the Medical College of Wisconsin and also the director of the endocrine center there. He started his practice in 1982 and has over 100 publications and chapters and is considered an international expert on clinical disorders of pituitary and adrenal function. He was instrumental in establishing the nighttime salivary cortisol diagnostic test for Cushing's. So you could say he's very much an expert in the diagnosis of Cushing's, which is why we've asked him to join us here today. We will be holding questions until the end of this presentation, but you are free to submit your questions as we go along. In the control panel, there's a spot to submit your questions. And with that, I'm going to hand over the presentation to Dr. Finn Ling.
Well, thank you, Alyssa. I'm honored to be asked to present regarding the clinical biochemical diagnosis of Cushing syndrome this morning to members of the Cushing Support and Research Foundation and all the members. This is a fantastic organization with certainly the best website available on information regarding this diagnosis and treatment. I would like to start off by saying that this is one of the most challenging problems in clinical endocrinology, possibly all of clinical medicine. So I will try to make this as straightforward as possible. It can be quite complex, and I'm certainly interested in entertaining questions at the end of the presentation. I think we should start with a definition, what Cushing syndrome means. It's simply the biological effects of excessive cortisol secretion from the adrenal glands or treatment with steroid compounds such as prednisone and other steroid compounds, whether they be oral, injected, topical, or inhaled. The myriad of biological effects of cortisol excess will be mentioned as we go along. The first patient that was ever seen with Cushing syndrome was in late December of 1910 in the office of a neurosurgeon in Baltimore whose name was Harvey Cushing. And this young woman had obesity, excessive facial and body hair, and hypertension, as well as absent menstrual periods. And she is the index case of this disorder. But since 1910, a lot has changed. And Cushing syndrome not only looks like this, but now it's changed. It may look like this, or this, or this. And one of the points I want to make during the next few minutes is how did that all happen, and how do we make the diagnosis of Cushing syndrome in people who don't look like the index case. So let's start off with a little bit of just review of pituitary and adrenal function and how this system all works. And what you see here is the pituitary gland, and the adrenal glands. Under normal circumstances, part of the brain called the hypothalamus generates a hormone called CRH, which stimulates the pituitary to make ACTH, which then in turn stimulates the adrenal glands, which reside above your kidneys, to make this very important steroid called cortisol, cortisone, as many of you may refer to it as. And what we know is that this system is robust, dynamic, and responds to all sorts of stress. It's a stress system. So many forms of stress activate this ACTH cortisol axis. But many other common clinical disorders may also be associated with high cortisol levels, not to mention alcoholism, narcotic withdrawal, many patients with neuropsychiatric disorders, and actually people who are starving, and patients with eating disorders. Patients with end-stage renal failure have high cortisol levels, as well as patients with poorly controlled diabetes and pregnancy, particularly the final stages of pregnancy, are a state of high cortisol levels. So there are many conditions in humans that activate this complex axis that are not pathologic, but are really physiologic. That is, that they're just responses to underlying disorders. But pathological Cushing's syndrome is what we're really talking about today. And that can occur because of a tumor in the pituitary gland that makes ACTH that causes the adrenals to become enlarged and produce too much cortisol. And these tumors can also reside in other places, although 90% of ACTH-secreting tumors are in the pituitary. 10% are somewhere else, sometimes referred to as ectopic ACTH, and they can occur in the lungs, the pancreas, and many other organs. Now, patients with this type of Cushing's usually present with weight gain, full face, what's sometimes referred to as a moon facies, plethora, that is, their face is often red. They have increased fat above their clavicles, and they frequently have high blood pressure, diabetes, or osteoporosis. They often have myopathy, which means they're weak, especially in the proximal muscles, and they have a variety of neuropsychiatric problems and cognitive problems. They may have swelling in their lower extremities, decreased gonadal function, and in women, they may have excessive hair growth in male hormone levels. Now, another form of cause of Cushing's syndrome is disorders of the adrenal gland per se. So tumors, sometimes one, sometimes two tumors, or more than two tumors in the adrenal glands can secrete cortisol in excess. This is not related to ACTH in the pituitary, so ACTH levels tend to be very low in these patients. Now, this disorder has emerged as being somewhat different than pituitary or ectopic Cushing's, because these nodules are usually incidentally discovered. They're just someone gets a CT scan of their abdomen for some unrelated reason, and they find a nodule in the adrenal gland. The cortisol excess in these patients is usually mild and sometimes intermittent. It's not always present. But surprisingly, they still have, despite the mild nature of the cortisol excess, high blood pressure, high blood sugars, low bone density, often with vertebral compression fractures, fractures of the vertebral bodies in the thoracic spine and lumbar spine. And the reason that even though the cortisol excess is mild, that they have all these metabolic problems is probably related to the fact that these nodules have been present for years, and they've had mild cortisol excess for many years. This condition is sometimes referred to as subclinical Cushing syndrome. So one of the things I think that needs to be said, and I been trying to convince clinicians of this for 20 or 30 years now, is that Cushing syndrome probably is not rare. Many studies have shown that if you look at all people with diabetes, it's about 0.5 to 5%. In many studies, it's probably closer to about 1%. Somewhere between 0.5 and 1%. Hypertension, about the same. And osteoporosis, it's anywhere from 3 to 11%. Now, 1% doesn't sound like a big number, but 1% of a big number is a big number. so that I think this is overlooked in many patients with diabetes, hypertension, and certainly osteoporosis. And then what's really been surprising is the recognition that cortisol excess and Cushing syndrome is very common in patients who have these incidentally discovered adrenal nodules. And conservatively, 10% to 35% of patients with incidentally discovered adrenal nodules may have mild Cushing syndrome. Now, why is this important? Well, we know that Cushing's syndrome is the relationship between cortisol and morbidity and mortality is sort of like a U-shaped curve. We know that low cortisol levels are associated with bad outcomes, but it's very clear in patients with overt Cushing syndrome that they have increased morbidity and mortality, cardiovascular mortality particularly. But recent studies in the last year and a half or 2 years have shown that even patients with this mild degree of cortisol excess probably have significant cardiovascular risk and cardiovascular mortality, so that all patients with cortisol excess need to be taken seriously and treated appropriately. The first thing I do when I see a patient with suspected Cushing's is ask them to bring in photographs. When you see a patient for the first time, you really don't have any framework to recognize the clinical change that has occurred over months or sometimes years. This is a young woman before the diagnosis and what she looked like 2 or 3 years later after 60 or 70 pounds of weight gain. And similarly, this is a woman before and after treatment with Cushing's. The dramatic change that occurs after you remove the offending tumor, whether it's in the pituitary or the adrenal glands, is often dramatic. This is a change in just 4 months period of time. And this is a young woman who had an unusual fracture of her femur in her mid-20s associated with significant weight gain. And looking back at a photograph taken 18 months earlier, I think the changes in her physical appearance are dramatic. And this is a young woman in the middle of this photograph who was sent to me many years ago and was found to have pituitary Cushing's and had a pituitary tumor removed. And this is her photograph a year later. The diagnosis and effective treatment of this disorder changes people's lives in a very, very positive way. And this is a gentleman who was referred to me a number of years ago. He was actually diagnosed by a friend of his who was a veterinarian. He and his vet friend were at a cocktail party, and his vet friend said, you're not running with me anymore. Why aren't you running anymore? And he told him how weak he was and gave him all his symptoms. His veterinarian friend looked at him and said, "You sound like one of my dogs with Cushing syndrome." And it turns out that Cushing syndrome is very, very common in dogs. So this gentleman went to his primary care physician and said, "My vet friend says I look like a dog with Cushing's. Can you work me up?" And sure enough, he did have Cushing's and was referred to us and had a tumor in his lung that was making ACTH. It was removed. And he sent me this photograph a year later. Again, the diagnosis and treatment of this disorder changes people's lives. And this is a young woman. Does she look any different than those other women patients? Probably not. She does not have Cushing syndrome. She just has diabetes and hypertension. Exhaustive testing, this woman did not show any evidence of Cushing syndrome. So the clinical diagnosis of this is very challenging since Many patients look like they may have Cushing syndrome and don't, and some that don't look like they have Cushing syndrome do. So we need to rely on biochemical testing to establish the presence or absence of pathologic Cushing syndrome. So I'm often asked by clinicians which patients should be screened. Who should we evaluate for this disorder? Well, I think the guidelines that were published about 8 years ago suggested that these signs and symptoms in patients should be considered for screening. In patients who have facial rounding with plethora, often associated with weight gain, increased fat in their above their clavicles or behind their neck, and cutaneous wasting means thin skin with easy bruising. Now, stria, or stretch marks on the abdomen that are purple or red, are often seen in patients with Cushing's, but only in young patients with Cushing's. People over 40 rarely have these stretch marks. Now, muscle weakness is often in the proximal muscles and in the thighs, particularly sometimes the upper arms. And this is often a subtle manifestation, and is often present in older patients with Cushing's, and their weakness is often just attributed to their age, which is often unfortunate. Women frequently have increased facial hair. It may be lanugo. Lanugo means very fine, sort of white, fuzzy hair, like baby hair, or increase in terminal hair growth. That's the kind of hair that you would need to shave. And this is not an uncommon problem in young women with Cushing's. Children, the sine qua non, or the most important clinical findings in children with Cushing's, which is it's rare in children, is that they stop growing. So, but in addition to patients who have physical findings that are consistent with Cushing's, patients with the following disorders need to be considered for screening. Certainly people with diabetes, hypertension, dyslipidemia, high cholesterol. Again, about 0.5 to 1% of these patients may have unsuspected hypercortisolism. So if any of those patients have any of the signs or symptoms on the previous slide, screening tests should be performed. My personal bias, currently not supported by any long-term studies, is that young women with polycystic ovary syndrome, particularly if they're overweight, need to be screened for Cushing syndrome. I personally see 2 or 3 young women every year who have been walking around with a diagnosis of polycystic ovary syndrome for a while, and they really have Cushing syndrome. And then women who have absent menstrual periods or decreased menstrual periods, or men who have decreased libido and impotence and low testosterone may need to be considered. And as previously mentioned, certainly osteoporosis in a young patient, middle-aged patient, the diagnosis of unsuspected Cushing's should be considered, as well as all patients who have an adrenal nodule that's found incidentally. Now, one of the other things I always think about when I see a patient with high cortisol levels or suspected high cortisol levels is the specific salmon before it begins its fluvial migration up the Sacramento River. And studies done in the 1960s at Stanford show that salmon, as they go upstream, and I think if any of you have watched salmon go upstream, it's a pretty stressful event. Develop high cortisol levels. And they get fat redistribution in the middle part of their body and cutaneous wasting. They get very thin skin, scales. And so they have clinical manifestations of high cortisol levels. And because of the high cortisol levels causing immunosuppression, they get superficial fungal infections. So this is an example in nature where stress and high cortisol levels can lead to physical and clinical manifestations similar to those in pathologic Cushing syndrome. So, as I mentioned on a previous slide, it's important to realize that some people with high cortisol levels don't have Cushing's syndrome. They have high cortisol levels for other causes, such as pregnancy, a diagnosis that's usually pretty easy to establish, depression, many other psychiatric conditions, alcohol, end-stage kidney disease, and poorly controlled diabetes. But other things, many forms of stress, pain, surgery, hospitalization, of course, eating disorders, intense chronic exercise can all be associated with excessive cortisol secretion, not due to pathologic Cushing syndrome. These diagnoses always have to be taken into consideration when making this diagnosis. This slide illustrates the current recommendations for biochemical evaluation. What tests should your physician do if this diagnosis is suspected? And we're going to go over the 3 tests that are currently recommended. 24-hour urine cortisol, usually more than one test is recommended. A test called an overnight 1 milligram dexamethasone suppression test, and then late night salivary cortisol test. Now, obviously, before you do any test, complete history has to be taken to make sure the patient's not getting steroids, whether they be inhaled, injected, or oral or topical steroids, because they can confound the evaluation and, of course, cause Cushing syndrome. But any abnormal test of these 3 tests, certainly you have to exclude these physiologic causes I just mentioned on the previous slide, but all patients who have an elevated cortisol level or any of these 3 tests should see an endocrinologist. This diagnosis needs to be made and established and confirmed by an endocrinologist. So let's go over these 3 tests, the urine cortisol first. Now, the urine cortisol measures a 24-hour collection and should assess the daily secretion of cortisol. However, the amount of cortisol that appears in the urine is only 0.1%, 1/1000th of the cortisol production made by the adrenal glands every day. So it is a very insensitive and poor test for the diagnosis of Cushing's, unless the Cushing's is severe. And since most patients with Cushing's usually have mild disease, this is a very, very poor screening test. And in my opinion, should never be used as the initial test for the diagnosis of Cushing syndrome. The overnight low-dose dexamethasone suppression test is widely used all over the world. It actually developed in the 1960s, believe it or not. Not very many tests that were developed in the 1960s are still being used. But dexamethasone, which is a synthetic and long-acting steroid, a small dose, 1 milligram, is given by mouth at 11 p.m. And the patient goes to the laboratory the following morning, usually before 9, to get a cortisol level. Now, after this test, in normal people, the cortisol decreases to less than 1.8 micrograms per deciliter. And if there's any of you calling in from other parts of the world, it's measured in standard international units, which is 50 nanomolar. But any cortisol level greater than 1.8 micrograms per deciliter suggests possible Cushing syndrome. It's not diagnostic, but it certainly raises suspicion. And although this test is very sensitive, that is, almost all patients with Cushing's, not all, but almost all patients with Cushing's have an abnormal test. It is not always specific. That is, there are many patients with abnormal tests, about 15%, have what we call false results and don't have Cushing's, and they might have kidney failure, they might be on birth control pills. There's a lot of things that can cause abnormal tests that are not Cushing syndrome. But a normal test makes the diagnosis unlikely. And finally, late night salivary cortisol. Now, this is a simple test to execute, and multiple samples can be obtained easily. The patient is asked to do a saliva test at 11 p.m. or at bedtime. Some people it's later than 11 p.m. Sometimes it's a little earlier. But it's a simple test. It has near perfect sensitivity in the diagnosis of patients with ACTH-secreting tumors like in the pituitary. But it's not quite as sensitive in patients with adrenal Cushings. But a normal test almost clearly excludes the diagnosis of a pituitary tumor. Multiple samples are needed, and this is a test that's ideal for patients with suspected cyclical Cushings and intermittent Cushings because multiple samples can be obtained at 11 p.m. over an extended period of time. It's simple. The samples are stable at room temperature for several days and are usually mailed to the reference laboratory for testing. And the reason this test is so valuable, these are, I don't know how well you can see this slide, these are 7 normal people. And these are cortisol levels drawn throughout the day every 20 minutes. And as you can see, cortisol levels tend to go up, and this dotted line is 8 o'clock in the morning when people are sort of getting up. You can see cortisol levels tend to increase early in the morning hours and fall off as the day goes on. But you can see there's a lot of scatter, a lot of variability in cortisol secretion. And these are normal people. But look here late at night, around midnight, 24-hour, 100 hours. Look how low the cortisol levels. So cortisol is reliably very low around bedtime in normal people. And accordingly, when people have Cushings, the first thing that happens in Cushings, particularly pituitary Cushings, is the cortisol levels late at night tend to go up. And that's the most sensitive diagnostic test and is abnormal before any other test is abnormal. And there are many ways of collecting saliva cortisol levels. We use this cotton swab, and patients chew it or roll it around in their mouth and get it wet, soak it, put it in this plastic tube, and it's mailed to the laboratory for analysis. As you can see, it's easy to obtain, and it's often even used in animals. It's so simple to obtain. This little guinea pig is doing her own sampling. So, a summary of the testing. If both dexamethasone suppression test, DST, and late-night salivary cortisol, LNSC, are normal, the diagnosis of Cushing syndrome is very unlikely. Now, elevations of these tests are not always specific for Cushing syndrome, and many other diagnoses and factors need to be considered when these tests are abnormal. The urine cortisol lacks good sensitivity and should never be used alone by itself to exclude Cushing syndrome. And establishing the diagnosis of Cushing syndrome and determining its cause requires the expertise of an endocrinologist. Now, I'm going to just briefly go over, once you make the diagnosis, what the cause of the Cushing syndrome is, which is obviously important in terms of determining treatment. And the critical thing is measuring plasma ACTH. Obviously, if the ACTH level is low, that means the patient has adrenal Cushings, and we image the adrenal gland. In contrast, if the ACTH is normal or elevated, the patient has an ACTH-secreting tumor, the majority of which, of course, are in the pituitary, 90%, and we do an MRI of the pituitary. Now, if the pituitary MRI is normal, and it is in about 40 to 50% of patients who have pituitary tumors secreting ACTH, so then we do a test called bilateral petrosal sinus sampling for ACTH, and I can answer questions about that if people do have questions, but it's the most specific test to distinguish between pituitary and non-pituitary ACTH-secreting tumors. Obviously, if the MRI is clearly abnormal, we send the patient to pituitary surgery. So 2 examples of patients with Cushing's, and kind of what this looks like circa 2016. This is a 51-year-old woman with hypertension for 1 year, not in good control. And she had a CT scan of her chest to exclude some kind of cardiac problem for high blood pressure. She was seen by a cardiologist, and they discovered about a 1.5, 1.4 centimeter left adrenal nodule. So a nodule in their adrenal gland, not something anticipated in the evaluation of her high blood pressure. And she's on 3 medications for high blood pressure, and her blood pressure is 150/84, not so well controlled. But you can see she weighs 130 pounds, and her body mass index is 22. This is a very lean woman who looks healthy and certainly doesn't look like she has any evidence of cortisol excess or high cortisol levels. But here's her photograph. We saw that earlier. And here is the nodule in the adrenal gland. This is the liver. This is the top of the left kidney. And you can see there's a nodule here in this adrenal gland that shouldn't be there. Now, her biochemical studies show that her salivary cortisols are in the high normal range. This is often what we see in adrenal Cushings. Sometimes they exceed the normal range. Some people think the normal range is about, upper limits is 3 nanomolar. Some people use 4 nanomolar. It depends on kind of where you set on that. So the reference range does change. Most labs in the United States have an upper range of normal of about 3 nanomolar. So these would be considered abnormal in many labs. The urine cortisol is clearly normal, 13. Normal's less than 50. But the dexamethasone suppression test, the cortisol was 8.1. Again, remember the normal is less than 1.8, and she has a very low ACTH level. So we suspect this is a cortisol-producing adrenal tumor. And it was taken out, and right after surgery, a week after surgery, her cortisol levels are very, very low because the contralateral adrenal gland, the right adrenal gland, is suboptimal at this point, but will recover, and did recover, and her hypertension resolved, and she's on no medications. And this is about 5 or 6 years ago, so she's still doing very well without any antihypertensive therapy. Now here's another man, a 20-year-old man with accelerated, very high blood pressure, certainly for a 20-year-old, and also has near osteoporosis. This is a very low bone density. In 20-year-olds, we just call it low bone density, but this is a very low bone density for a 20-year-old man. But he's not got any features of Cushing's. He's got some acne, which is very common actually in younger patients between about the ages of 17 and 25 who get Cushing's. Frequently, acne is the most prominent clinical feature. But he's lean and muscular, but his urine cortisol, done by a primary care physician, was elevated. And this is what he looked like. And then he was referred, I want you to go back. We'll go back. This is the year 2000, July 2000. I want to make it clear that what year we're at here, 2000, so this is a long time ago. And his urine cortisol levels are elevated, and they do another test. This is a test we don't do any longer, but it was done in a academic medical center where he got dexamethasone 0.5 milligrams every 6 hours for 2 days, and his cortisol levels, as you can see, disappeared. It was suppressed. So they said he had pseudo Cushing's. They didn't think he had true Cushing's, and this is, again, 2000 is the year. So he was dismissed. Well, 6 years later, he looked exactly the same. And September of 2006, his hypertension is now controlled with 3 medications. Urine cortisol is still elevated, 165, normal less than 50. His late-night salivary cortisol levels are very high, 5.3 and 6.8. And again, the dexamethasone suppression test yielded a cortisol of 6.2. Again, remember, normal is less than 1.8. And this is a high ACTH level. So he had a pituitary tumor found on MRI and confirmed with inferior pituitary sinus sampling, and he had a pituitary tumor removed in early 2007. And here he is 5 years later without hypertension and no medications, doing very well. So the diagnosis of Cushing's syndrome can be subtle clinically and sometimes difficult to establish even in the best of hands. In summary, Cushing syndrome is more common than previously thought and confers significant morbidity and mortality without diagnosis and treatment. Patients with clinical features of excessive cortisol, including physical findings, hypertension, diabetes, osteoporosis, and adrenal nodules, should be screened. Late-night saliva cortisol test and the overnight dexamethasone test are the best screening tests. And in conclusion, the diagnosis of Cushing syndrome is the most challenging problem in clinical endocrinology and possibly in all of medicine. Thank you very much for your attention, and I'm happy to address any of your questions.
So Dr. Findling, I assigned a couple of questions to you that you should see in the questions section.
Yeah, I can't see them. So would you, oh, here it is. I think I see one question here. Would you comment on the diagnostic test to exclude pseudo-Cushings using Dexamethasone CRH? Well, I'm glad someone asked that question. Can I go back on my slides now? Or not? I can't move my slides. There's some way I can move them backwards. I can answer the question.
You should be able to go back a few slides. And you're...
I can't do that.
Okay.
No. Can that be changed so I can go back?
Can you click on, in your slide deck, go to slideshow? Can you click on slideshow at the top of the screen?
Yeah. I'll go back. Yeah, that worked. Okay. So here's this last, the question is whether this test, the DexCRH test, confirms the presence or absence of pseudo-Cushings. And I don't personally like this test. I don't do the test. I think it's laborious, expensive, and time-consuming. It is done in some places. We've abandoned it personally. Some other testing I do now, but this is not a test I use. And here's one of the examples, and we've seen other patients like this. This is a patient, again, remember, this is a young man who had Cushing's considered in 2000, and salivary cortisols were not done then, probably because they were not available in the year 2000. And he suppressed with low-dose dexamethasone here very nicely. And then they did the DexCRH test, and this is was considered normal. So they considered this pseudo-Cushing. So they missed the diagnosis of true Cushing's in this man with the DexCRH test. So this test is still used. I must tell you I haven't used it for at least 10 years, but it is employed in some centers, and but I don't personally use it. I think it's just a lot of work for not much gain. And here's a case where a patient had a normal test. The cortisol levels were very low after DexCRH and didn't stimulate after CRH, and the patient truly had Cushing's disease. So I think it has some diagnostic problems. Are there any other questions?
Yeah, there should be more questions in that list.
Okay, how do I can't find them.
So
I don't see any questions.
all right, so I think it might be helpful if I'll just read the questions out.
All right.
To you. So can you have an ACTH producing tumor in the liver?
The question is, I don't think I need to repeat it because everyone can hear you, Alyssa, is that right?
Mm-hmm. Yes.
ACTH secreting tumors can reside almost anywhere. I must tell you, I've never seen one in the liver unless it's metastasized. most ACTH secreting tumors that are not in the pituitary are often in a group of tumors we call neuroendocrine tumors. Neuroendocrine tumors can start almost anywhere, and many of them, particularly if they're in the gastrointestinal tract, can metastasize or spread to the liver. And I'm sure there have been liver cancers that make ACTH, so I'm sure it has happened, but it's not common. But I think if someone has a tumor in their liver and it's making ACTH and they have Cushing syndrome, there's a very high, strong likelihood that the tumor is spread there from another site.
Got it. We have a follow-up from the previous question about pseudo-Cushing. So the question is, what would you use to differentiate pseudo-Cushing?
Well, that's a fair question. I take one of two different strategies. First of all, if I do a very thorough history and physical examination to be sure that many of the things that cause pseudo-Cushings, particularly alcoholism, are not present. I have personally missed Cushing syndrome in a couple of patients who I thought were either had an adrenal tumor or a pituitary tumor, and they actually, the reason for their Cushing's was chronic alcoholism. They were not being forthright about their alcohol consumption. So I've learned to be very vigilant about a detailed history in all patients to make sure they don't have some cause of their Cushing syndrome that might be, or high cortisol levels that might be well appreciated. If the history and physical are not clear cut, then what I do is I sometimes repeat testing in 6 months or a year, depending on how anxious the patient is about the diagnosis. In patients who are not patient, and many of them have a lot of anxiety about this and want to make a diagnosis quickly, my current go-to test, and I certainly think it has some, like all these tests, they have pros and cons, is a test called a DDAVP stimulation test. And I'm sorry I don't have a slide on this, but the DDAVP test is a hormone. DDAVP is a hormone that stimulates ACTH in patients who have Cushing's syndrome from ACTH secreting pituitary tumors. So this is only helpful in patients with ACTH secreting pituitary tumors, which most patients, the differential diagnosis in pseudo-Cushing's versus Cushing's is almost all patients with ACTH secreting tumors, their ACTH levels are not low. And DDAVP stimulates ACTH from these tumors, but it doesn't stimulate ACTH from people who have these pseudo-Cushing's conditions like alcoholism, depression, and poorly controlled diabetes. So that's the test I use. Now the problem with the test is it's a little difficult to find out what's considered normal and abnormal, and it varies from lab to lab, and there's various reports of this. It's used widely in Europe, actually, probably more so than in the United States. But I think it's simple to perform, much less expensive than the Dexamethasone CRH test. And when I'm forced to do something from a diagnostic standpoint, I use the DDAVP stimulation test. Now, is it perfect? Of course not. None of these tests are perfect. I think that's pretty clear. But it is a test I do when there is some clinical or biochemical concern about the diagnosis to help the patient and the referring physician establish the presence or absence of true pathologic Cushing syndrome. It's called the DDAVP stimulation test. It's, again, widely employed in Europe. Again, it takes only about 60 minutes to do it in the clinic or in the office. And you measure ACTH and cortisol, ACTH probably being the most important test. before and after the administration of this hormone DDAVP.
More questions about testing. So can someone have Cushing's and have high midnight salivary cortisol results, but have low cortisol during the day?
Well, I don't know about low cortisol levels, so cortisol levels may be normal during the day. Obviously, patients who are third shift workers, for example, or who have been trained themselves to a different circadian rhythm, that is, they're kind of what happens. People who work the 11 p.m. to 7 a.m. shift all the time, their circadian rhythms really changes so that they have high cortisol levels at 11 o'clock and low cortisol levels later in the day. With the exception of those patients, patients who have early Cushing's disease and ACTH pituitary tumors may have the only test that's abnormal is cortisol levels late at night are elevated. And they may be normal during the day. They're not necessarily low during the day. They wouldn't be subnormal, but they may be in the normal range, but not in the subnormal, below normal range.
We have a few questions about cyclical Cushings. And the first question just being, how can we test for cyclic Cushings? What's your advice on that?
Well, I mean, here's the, I'm not sure how to answer this question. Let me just say this. In the beginning of Cushing's, that is early in the phase of Cushing's, and the reason we know that the statement I'm about ready to make, you probably not heard before, but the reason that we know it's true is because we know what recurrent Cushing's disease looks like in patients who've had ACTH-secreting pituitary tumors removed and then they recur. What we know is that about 20 to 25% of patients who've had cures and treatment for Cushing's disease, ACTH-secreting pituitary tumors removed successfully and gone into remission, normal cortisols, about 20 to 25% of them recur within 10 years. Surprisingly high. And we know by following these patients sequentially that the first test that becomes abnormal is elevations of late-night salivary cortisol. So it's the earliest biochemical marker of Cushing's disease, by far. Actually, it's not really the earliest. The earliest is actually the DDAVP stimulation test, it turns out, but that's a little impractical to do. The late-night salivary cortisols are much more practical. So we know that. But when that occurs, their cortisol levels are not always elevated, or they're intermittently elevated early on. So they have, you do a couple late night salivary cortisols, one's normal, one's low, then you do a couple more and they're both normal, then a few months later you do them both, they're both elevated. So there's intermittency probably in all patients early in the course of Cushing's. So if that's a strong consideration in patients, then what I do is I do several late night salivary cortisols over a period of 6 to 12 weeks, depending on the signs and symptoms and what my index of suspicion may be, and we may do as many as 12 to 24 late night salivary cortisols over that period of time. And then sometimes, if I'm still in a quandary and I'm not still sure what to do, I do the DDAVP stimulation test, because that test turns out it's even abnormal even before the late night salivary cortisol levels are in patients with recurrent Cushing. So I suspect in patients with early Cushing's disease and intermittent mild Cushing's, that test is usually going to be abnormal. So that's another test I use. That's another scenario where I use that test. Let me also just say that this whole evaluation that I've gone over in the past has evolved over the last 30 years. And so it's continuing to evolve, and I'm sure that in the future there will be even better diagnostic tests available to establish this diagnosis. So I don't want to make it sound as if there's not being there will be more progress, I think hopefully in a positive way, so that patients can have an earlier diagnosis and effective early treatment for this condition.
So somebody's written in to say that they've been diagnosed with Cushing's, and they even had IPSS, and I think you might want to comment on what that is, which confirmed that it was pituitary, but the MRIs can't find the tumor. So what's next?
Well, if a patient truly has Cushing's and I assume they did because they had IPSS. IPSS is inferior petroso sinus sampling. And this is a test which a skilled and invasive radiologist samples blood actually from the venous drainage of the pituitary on the right and left side. And then during the test, the stimulatory hormone CRH, which is the hormone from the brain, the hypothalamus, that stimulates ACTH is given, and then ACTH levels are measured before and after that. And with nearly 100% certainty, you can establish the presence or absence of a pituitary source or pituitary tumor making ACTH. Occasionally, you can actually localize the tumor, whether it's on the right side or the left side, although that's certainly not always possible when doing this test, but occasionally you can get good lateralization data, so you can tell the surgeon ahead of the time, well, this tumor is clearly on the left side, is clearly on the right side. Now, in a patient who has clearly ACTH-dependent Cushing's, and it's pituitary, confirmed by this test, inferior petroso sinus sampling, even if the MRI is negative or normal, the next step is to be referred to a skilled, experienced pituitary neurosurgeon. And if you're in good hands, the likelihood is still very high that they'll find the tumor during surgery and remove it successfully. And that's the current guidelines. That's what everyone would recommend. The important part of that statement was very experienced pituitary neurosurgeon. Operating on Cushing's disease is much different than operating on other pituitary tumors. Tumors are obviously very small, they don't show up on MRI, and they can be very difficult to locate unless you have someone who's very skilled and experienced. And the success rate is really dependent on the experience of the neurosurgeon.
We've have a question about testing hair, cortisol in hair, and are you familiar with that? And what do you think that's kind of the next evolution?
It's an interesting, it's a very good question. It's been the rage in the last few years, mostly in the Netherlands, and there are a couple places in the United States that are measuring hair cortisol. And what this presumably is a reflection of is the integrated cortisol secretion over the period of time the hair grows. So you cut off from your hair. I think it's 2 inches. I'm not sure if 1 to 3 inches, depending, because I don't have much hair, so this wouldn't work very well for me, unfortunately. And they measure it, and they use a solvent and they extract the cortisol from the hair. I mean, it's a laborious procedure. It's not very obviously costly. It's only research available in research centers now, and measure the cortisol. And that's a reflection of, say, your cortisol secretion over the past few months. Well, a few weeks. The problem, of course, is that since many of us have stressful living situations, stressful jobs, whatever, cortisol levels tend to be high. And so it may be very good for diagnosing high cortisol levels, but it's not going to be very good in distinguishing whether it's due to a pseudo-Cushing's or physiologic condition or whether it's a pathologic cause. So currently, it's not being used in a diagnostic fashion, but certainly it has some potential, and I think it's being studied, but heretofore, up to this point in time, there's no convincing evidence that's going to provide any great insight into the presence or absence of true Cushing syndrome. But I would stay tuned.
How sensitive is the salivary midnight test? Can stress affect the test results?
Well, of course. You know, this is a dynamic system, and stress is a very important component in establishing the accuracy of any test, any time of the, it doesn't matter whether you're talking about a urine cortisol or any test, any of these tests. Late night salivary cortisol, I've learned to. I had a patient a number of years ago who came in and had, you know, some elevated levels and taken at 11 o'clock, and I said, well, what do you do? And he worked second shift, and he was a police officer. Well, I mean, I said, you know, in the inner city of Milwaukee. Well, I could say a little stressful. So he comes home at 11 and does salivary cortisol. I mean, it's, you know, it's not surprising that it's elevated. So I think you have to take in context any cortisol level, regardless of when it's secured or how it's secured. And the late night salivary cortisol is no exception. So proximal stress, which occurs even within a few hours of the time you collect it, may cause false elevations of the test. And I think that's something that, and people, again, who have abnormal sleep-wake cycles, I mean, you'd be surprised how many times I've had people with elevated 11 p.m. salivary cortisols, and I ask them, well, when do you go to bed? And they say, oh, 4 a.m. Okay, 4 a.m. I said, oh, that's not what I mean. You just don't expect that from some people. But some people just stay up all night watching Netflix, and then they, you know, go to bed at 4 o'clock in the morning and wake up at noon. I mean, that's how some people live. I mean, I don't live like that way, but so you have to take a very careful history about what bedtime is for people. And I think that's one of the important things in assessing any late night salivary cortisol. What late night for some people is not late night for others.
Got it. This is an interesting problem, and I think it's something that a lot of patients struggle with, and they probably don't go to an endocrinologist like you, who's very educated in Cushing's diagnosis. So in this particular case, they were referred to an endocrinologist through a primary care physician, and the endocrinologist said they wouldn't accept the referral without a confirmed possible diagnosis, but the only test ordered was a 24-hour urine cortisol.
Mm-hmm.
What do you think this patient should do? You know,
well,
they're afraid it's not a good enough test.
Well, as I said before, a urine cortisol is not an adequate screening test. If it's high, I mean, fine. I mean, if it's elevated, okay, good. Then people can move forward. But, you know, a normal test doesn't exclude the diagnosis. I mean, only about, I mean, it depends whether you're talking about adrenal or pituitary Cushing's. Somewhere between 30 to 50% of patients with true Cushing's have normal urine cortisols. I mean, I hardly a week goes by that I don't see a patient with Cushing's that has normal urine cortisol. I would say, I see 3 or 4 people like that a month. So most of them have adrenal Cushing's, but some don't. Some have pituitary Cushing's. So it's just not a sensitive enough test. So I would advise a patient like that to go see another endocrinologist who will do a late night salivary cortisol, or a primary care physician. You know, it's currently widely available in many reference labs in the United States. It's you know, it's not simple to secure the test, and since it can be mailed to the reference lab, I mean, we provide postage. I mean, it doesn't cost the patient anything to send the samples. I would advise the patient to, if they have any concern about it, to go ahead and do that. So see another endocrinologist or primary care physician who will order late night salivary cortisol or a dexamethasone suppression test, either one.
Yep. So somebody asked here if Cushing's is hereditary.
Well, that's a good question. Pituitary Cushing's is rarely hereditary, but it can be. But the specific genes that may cause those hereditary Cushing's in the pituitary are not well understood yet. I have not, I've seen probably well over 1,000 patients with Cushing's. I think I only have 2 families that I know of that had a father and daughter with Cushing's. I doubt if it was a coincidence. I have a husband and wife that had Cushing's, but it's not sexually transmitted, so don't worry. Adrenal Cushing's, on the other hand, is a different story. It's becoming very clear in the last 18 to 24, 36 months, last 2 or 3 years, that many patients with adrenal Cushing's have genetic disorders. So that I think what will happen in the next 5 or 10 years is that if you have adrenal Cushing's, that all patients with adrenal Cushing's will probably undergo some kind of genetic family screening, particularly if the nodules occur in both adrenal glands. So patients who have both, sometimes adrenal nodules are monolateral, that's just one adrenal nodule, but often they're in both adrenal glands. And if they're in both adrenal glands, then I think the patients really are going to eventually have a genetic. Now, some of the tests the genetic mutations that cause adrenal Cushing's, particularly with bilateral nodules, are not commercially available. One just became commercially available here in Wisconsin, at a lab here in Wisconsin, but and it's still in the infancy in terms of understanding this. But I think patients with adrenal Cushing's will undergo genetic testing pretty routinely in the future.
So we have a question about thyroid nodules. So can a thyroid nodule cause Cushing's?
Excuse me. Only if it's what's called medullary carcinoma of the thyroid. There is a thyroid cancer that can cause Cushing's, but thyroid nodules per se, unless it's called medullary carcinoma of the thyroid, that kind of tumor is associated with the development of Cushing's, but that's the only thyroid nodule or tumor that's associated with Cushing's. Now, having said that, there are some reports that a number of years ago that patients who have Cushing's, for whatever cause, tend to have a higher risk of nodules in their thyroid and goiters in large thyroid glands. Now, let me just say that may be selection bias. I mean, endocrinologists tend to be people who look at all glands, including the thyroid. So they're more likely to pick up, thyroid enlargement and nodules than, say, a primary care physician. But there is some evidence that nodular thyroid disease is more common in patients with Cushing's.
So after a patient has had a tumor removed from their pituitary, is it important to have annual brain MRIs, or are blood tests and urine tests sufficient?
Well, yeah, that's a very good question. And I think you probably get a little different opinion from me than from, say, a neurosurgeon and other people. I mean, neurosurgeons love to do MRIs and look at them and see how beautiful job they did. At a cost of $3,000 or whatever they cost. But quite frankly, if a pituitary tumor has been removed successfully and the patient has normal cortisol, or after surgery often low cortisol levels for a while, I don't repeat MRIs routinely. And the only difference of that is if it was a very large tumor to begin with. Usually the tumors are small. But if the patient has normal cortisol values after pituitary surgery for Cushing's, I don't repeat MRIs. No, I don't do that. Now, if they're recurring, obviously that's a different story. If their cortisol levels are going up again, of course, then we do pituitary imaging again.
So a similar question along the line of somebody who had Cushing's, had a pituitary adenoma removed, and now is on a small dose of hydrocortisone. But now the symptoms are getting worse again. They have diabetes and no weight loss, and feeling pretty weak. Can they be retested if they're still on steroids?
Oh, no. I mean, you have to obviously remove the steroids. I mean, if somebody's taking steroids, you can't do any testing. Well, you can do testing, it just won't be interpretable. I mean, it's going to be difficult to interpret. So anyone who needs testing, regardless if they have de novo Cushings or they have recurrent Cushings, or if they're on steroids, all bets are off. So you have to remove any exogenous steroids. The only exception may be inhaled steroids. Inhaled steroids are probably okay most of the time, and there's some caveats about that. But if you're using, say, inhaled steroids for asthma, they probably don't interfere very much with the testing. But if you had injected steroids, if you're taking oral steroids of any kind, they have to be discontinued before any testing is going to be reliable.
And you mentioned that so the 24-hour urine 24-hour urine test is not that sensitive for somebody who has had Cushing's and has been treated for pituitary tumor. What is the test that they should be doing regularly?
As I maybe didn't make that clear. I mean,
sorry.
the late every patient who has had Cushing's disease, and this is what this is a published guideline. This is what the guidelines say. I'm not. This is obviously my opinion, but the opinion of many other experts as well, based on the data, based on science. This is scientific evidence. Is that every patient who's had Cushing's should have late-night salivary cortisol levels checked on an annual basis for an indefinite period of time. Because that's the most sensitive way to find if they're having a recurrence. And that urine cortisol is, I mean, it's useless is maybe a strong word, but it's not very sensitive. So late-night salivary cortisol should be done annually. Now, if the late-night salivary cortisols are elevated, it doesn't mean you necessarily you don't need to panic. Just need to hang tight, because sometimes they'll be high for a little while and then they go back to normal. And people will have this intermittent Cushing's for a while and they feel fine. They don't have any symptoms. And in those patients, I do nothing. So I don't panic. But if you want to find early recurrence, late night salivary cortisol is the most reliable test by far.
So this person asked, if you had pituitary Cushing's, can you then have adrenal Cushing's?
Well, that's a good question. It's a complicated question, and I don't want to give a complicated answer. The answer is probably not, but let me just say this. If you have a pituitary tumor making ACTH, sometimes the adrenal glands get enlarged, they get big, we know that. And if it occurs over a long enough period of time, nodules actually form in the adrenal glands. So then you get nodules in the adrenal glands. Sometimes adrenal glands, both of them get nodules. And you take out the pituitary tumor, and the patients usually get better and they're fine. And sometimes those nodules will eventually regress and go away. However, occasionally I've seen at least one or two patients where you take out the pituitary tumor and the patient still has sort of mild Cushing's because the nodules have sort of become dominant and taken over. So it's possible, I suppose, that could happen. And I think but it's complex, and I think anyone with that sort of situation needs to be in the hands of someone who's got extraordinary expertise in the diagnosis and management of Cushing's.
I hope she heard that because she had a few questions along those lines. And to that patient, if you email us, we'll try to make sure that you are connected with an endocrinologist who is quite expert in this. Maybe this has been going on for a while, and just a quick question: what does DDABP stand for?
It's desmopressin, D-desmopressin arginine vasopressin. It's a hormone that the generic name is desmopressin acetate. It's a hormone that comes from the hypothalamus that regulates water homeostasis. That is how much urine you make, essentially. So it's also the lay term for it is antidiuretic hormone, but the scientific term is vasopressin. And it's a widely used hormone in patients with a condition called diabetes insipidus. That's where patients don't have the hormone vasopressin. It's also used actually for von Willebrand's disease, bleeding disorder. But it's a hormone that vasopressin, in addition to CRH is the hypothalamic hormone that stimulates ACTH, but also vasopressin, which is also a hypothalamic hormone, also stimulates ACTH. And but in normal people, when you give this DDAVP, the ACTH barely moves; it hardly moves at all. But in patients who have true Cushing's disease, have pituitary tumors making ACTH, it tends to cause an exaggerated and a robust ACTH response. So it provides some reasonable discrimination between normal people who don't have Cushing's, and people who truly do. But it's not perfect. I don't want to hold it up as being the gold standard. Unfortunately, I'm not sure we have a gold standard. We have a group of tests, all of which have pros and cons. And as long as we understand there's limitations and liabilities, in most patients, we can come up with an accurate diagnosis.
So I think I just want to clear up a question from someone who said, can adenomas produce ACTH or only cancerous tumors? I'm pretty sure it's non-cancerous.
Fortunately, most of the tumors, both in the pituitary and even not the pituitary, that make ACTH are benign. Now, obviously, cancerous tumors can, particularly pituitary tumors are rarely cancer. Now, I've been doing this for a long time, over 30 years, and I think I've seen, let me just think about this, 3 patients with ACTH screening pituitary tumors that turned malignant, well, maybe 4 now, I guess 4 that turned malignant and became cancer. But those were big tumors to start with, and that's 3 or 4, but that's I have a big denominator, so it's pretty rare. Pituitary tumors or non-pituitary tumors, ectopic tumors making ACTH, again, are mostly benign, but can be cancer and obviously need to be treated like that, and often radiation therapy, chemotherapy, whatever has to be done in addition to treatment for the high cortisol levels.
One of the things early on in your presentation, you mentioned that there's high mortality, high morbidity with Cushing's, and this person asks, is that just because they don't ever find it?
Well, obviously, the data is not. That's not how the data is accumulated. The data is accumulating people who have proven Cushing's, and we know that patients who are not well treated with proven Cushing's have they have a 5 times higher chance of dying within a 10-year period of time than someone in their same age who, say, doesn't have Cushing's. So that it increases what's called the standard mortality ratio significantly. And what's even more surprising, and then this is, again, scientific evidence and data that's just been published in the last 2 years, is that patients, even with mild Cushing's, very mild cortisol elevations, have increased risk for cardiovascular, heart attack, stroke, and death. So even mild degrees of cortisol excess can be associated with increased cardiovascular morbidity and mortality. So I think that all of us are humbled by some of this new data and realize that the importance of diagnosing even mild Cushing's and treating it may be important, particularly in young and middle-aged patients.
So, and this might be a question that kind of goes back towards like a pseudo Cushing's diagnosis, but this person says, can constant stress over 13 years as a child cause Cushing's?
Well, it causes high cortisol levels, and you can, it's like the salmon swimming upstream. High cortisol levels, and that can lead to clinical manifestations of Cushing's, but it's not pathologic. It's just due to stress, and assuming that stress has, been ameliorated or no longer present, the cortisol level should come back to normal. But here's one other caveat. I mean, if patients have that and have high cortisol levels and develop clinical manifestations, even when the cortisol levels come back to normal, sometimes the signs and symptoms of high cortisol levels do not regress so easily. So, and we know that even in patients who have true Cushing's and they have treatment, although many of them have dramatic clinical improvement, some of them still have some signs and symptoms of cortisol excess, as if the body, unfortunately, has some kind of metabolic memory. And so they have trouble getting their weight back to ideal body weight, and they still may have some signs and symptoms of cortisol excess. So that's unfortunate. And this happens even in patients who take exogenous or take steroids for, asthma or rheumatoid arthritis or whatever. Some of them have, developed Cushing syndrome from those steroids, and sometimes even after they stop the steroids, not all the signs and symptoms completely go away.
Okay, I think we're probably well over the amount of time we allocated to questions. I think what we'll do is end it here, and if anyone, and I'm very sorry if we didn't get to your question, but if you have other questions, we are always here. You can contact the Cushing Support and Research Foundation, and we really do try to answer all the questions that come through to us. So please contact us, and also please check out our website. A lot of these questions are answered on the website, and we actually, our last webinar was on the quality of life with Cushing's, and some of these questions were actually answered in that webinar. So with that, I just want to say thank you so much, Dr. Findling, for all your time and putting together your presentation. I found this really interesting, and I hope everybody else did. And also thank you to Strongbridge Biopharma. And we'll put this up on the website probably in the next week or two.
Well, thank you very much. It's been a pleasure, and I wish all the listeners, I hope they learned something, and I wish them well in their journey with Cushing's.
Thank you. All right. Well, thank you all, and we'll let you know when our next webinar is.
Okay.
Thank you.
Okay. Good morning. Okay. Bye-bye.
Bye-bye.